effect on coronary artery disease. So they fell by the wayside. Now, even in hyperuricemia, nobody has been able to demonstrate mortality or a benefit, though they have shown a cause and effect very clearly. There are quite a few studies which have shown the enhanced study, and there's another study also in which they very clearly demonstrated that even considering the other comorbid factors, every increase of 1.6 milligrams of uric acid resulted in an increase in cardiovascular events. Now, having said that, the other problem is that treatment has not really been adequately studied to show that there is a definite benefit. But having said that, look, if I am in the US and someone walks up to me with a gun in their hand and says, "Give me your wallet," I would most certainly give it. I will not question whether the gun is loaded or not. So it's something like that. If you have a uric acid which is beyond the normal range, what I do is I definitely bring it down. I may or may not continue with febuxostat. If the uric acid on follow a couple of times remains well below 4 milligrams, I even stop the febuxostat and review after a while. So at least, like I said, I do treat, and I know that there are not enough guidelines on this matter, but the treatment of a patient is always is far, far beyond guidelines above.
Absolutely, sir. And I think that is the whole discussion about that. We don't have to just go by whatever is written. We have to take individual patient, particularly in this scenario. If you look at the guidelines and everything, and research for that matter, in fact, I shouldn't say South, Asian population, and Asian population, I mean Chinese, Taiwanese, Japanese, Asian population, there is far more of this thought of reducing uric acid level than European and the Americas, where reducing the uric acid level is not that much focused onto as compared to more in the Asian. In fact, Japanese guidelines do suggest that we should reduce uric acid even in asymptomatic hyperuricemia, although they do not say that what is the aim of that, like in terms of what are we trying to prevent clinically. They do give cutoffs, they do say that it should bring down to this level, and they do say that they use febuxostat, although they are using febuxostat at a much lower dose. We are talking about 10, 20, 30, 40 milligrams as compared to European and Americas, which use 80 or even 120 milligrams. So there is certain geographical difference, how our genetics are made, those are different. So I completely agree with you. Treating patient is not just about looking at the guidelines. We have to look at how we have been doing, and certain things that we do, they are not captured in the academics. And unfortunately, in India, we don't have that much of robust backup where we start every single thing that we are seeing. So that is where we have to discuss. Dr. Krishnan Raju, you have something to add to this?
Just putting on a little more flesh on that. In US, I'm sure you heard of Dr. Dudley Johnson from Milwaukee, cardiac surgeon. So he always used allopurinol post CABG. And he was very, very keen that everybody should use it. And he produced a lot of papers on that, saying that this helps them recover faster and avoid a lot of complications. That anyway was what he was doing even 25 years earlier. I don't know whether he's still doing it. Second thing is, if patient is totally asymptomatic, but your patient already had a cardiovascular disease. Suppose I put a balloon question that he's symptomatic because he already had a cardiac disease. What do you mean by asymptomatic? Your patient you have projected is not asymptomatic. He already has an issue. He already had undergone a coronary stenting procedure. And I think if I remember right, hypertension, so on and so forth. So obviously he is already symptomatic. But in general terms, when you are talking of uric acid, if you are using asymptomatic, I think people understand that there is no uric acid related arthralgia or arthritis or renal problem. but that is not true. So even your cardiovascular manifestation may be included under symptomatic uric acid. Next, moving on to asymptomatic, totally asymptomatic uric acid. One of the suggestions given by a research paper was, in US, I believe, they would advise to use it if the serum uric acid level is more than 12 in men, more than 10 in women. That is one of the balloon suggestions that was given, though I normally take 6 as my cutoff. Diet and alcohol. I think the borderline hyperuricemias, asymptomatic, it is reasonably effective if you can restrict or stop alcohol, particularly binge drinking. And then diet, avoiding the red meat, avoid the organ meat, and avoiding the cauliflower, spinach, beans, etc., etc. So that can bring down the uric acid to some extent, maybe less than 6. So if there are no compelling indications, maybe you can try this diet and alcohol restriction. That is another suggestion which I have. But something else which also in our territory is valsartan has been shown to reduce uric acid. And statins, particularly atorvastatin and simvastatin, also have been shown to reduce uric acid by at least 20% or so. These numbers vary from study to study. So maybe if you are using statins, you can recheck your uric acid after proper statin therapy and then take a decision. Or if you are using valsartan for hypertension or heart failure, maybe that will take care of a borderline high uric acid. So those are the few comments which I had wanted to make when we are on that.
Thank you so much, sir. Sorry, I just wasn't very clear. When the guidelines say asymptomatic, they mean no urate deposition syndrome, not anything else. But anybody else got any thoughts on this in terms of what we are discussing? Hyperuricemia, how to tackle it in cardiovascular space. Floor is open. Anybody?
Anoop, Devashish here.
Yes,
have
Dr.
a question more than a comment. So I think what I'm hearing is that increased uric acid levels are linked with poor cardiovascular prognosis. But my question would be whether this is a independent risk factor, or as you know, I was hinting at, is this a marker for obesity and metabolic syndrome and a lot of other factors which are going on in addition to uric acid, which are independently leading to this poor outcome, and therefore uric acid, reducing uric acid, as has been shown by many studies, is not leading to any improvement in outcomes because it's maybe just a marker and not actually an independent risk factor for poor cardiovascular outcome. So any thoughts on that or any theory on that?
Yeah, so that theory question I can answer. So basically, this thing was and is a nightmare to differentiate association with causality with uric acid, because uric acid is elevated in all these patients. In fact, if you take population-wise studies, it's like PFO. 25% of walking people have elevated uric acid compared to what the cutoff that has been given, 6.5 and 7. 25% of them. But only 1% of them have got any urate deposition syndromes. On the other hand, if you take the patient who have cardiovascular disease, the uric acid levels are all over the place. So we really have no idea in terms of whether it is causality or not. So we did some animal experiment. There are actually some animal experiment where you knock off the this enzyme pathway, whatever I can't remember. You knock off the enzyme pathway that increases the uric acid level. You knock off, and after 3-4 months, you look at those animals. They are developing hypertension. They are developing cell damage, endothelial cell damage. They are developing all of this. So there is some thought process that uric acid, like what Dr. Kishan Raju was saying, Once it enters the cell, it is not your friend. It does damage. I don't think that that part is a clear no. It does damage a lot. The question is that reducing it, just like low HDL is associated with poor cardiac outcome. But when you increase that HDL pharmaceutically, that does not do anything. Versus if you increase HDL with diet and exercise, now that helps. So lot of it is maybe uric acid is the problem. It is a marker as well as the problem. But the way we are reducing the uric acid, maybe that is not the right way to do. Maybe diet and alcohol restriction is the way to do. Maybe that is how it will help. So the answer to your question is it is not absolutely clear, but there is some evidence that it is directly toxic. There is a lot of evidence that it is associated, and there is no evidence that reducing it makes it better. I will invite other people to give. Okay. Okay, yeah, the answer is clear, but the science is not. I'm sorry about that. Yeah. Okay. Anyone else has got any other thought? Chandramukhi madam, what do you do in your practice? We always have to force you to speak.
No, not like that. So, whenever we find uric acid levels, as sir has mentioned, more than 7 to 7.5, then if the patient was having cardiovascular risk factors like hypertension, diabetes, or already cardiovascular disease, then in my practice, I used to reduce the uric acid levels by starting febuxostat. But after you have brought up this topic for discussion, then I went through some data, and as Krishnaraju sir has told us about the study which was conducted in Taiwan, I also happened to go through that study. And in that study, raised serum uric acid levels were found to be an independent risk factor for the cardiovascular morbidity and mortality. So in patients who were non-hypertensives, non-diabetics, they had studied the effect of raised serum uric acid level, and they found that as already everybody has mentioned that it is having increased systemic inflammation, endothelial dysfunction, and increased arterial stiffness. So all these factors, they increase the cardiovascular risk and cardiovascular events. So as somebody was asking, like whether it is an independent risk factor, so it has been shown to be an independent risk factor for cardiovascular risk and cardiovascular events. But whether lowering the serum uric acid levels will be beneficial, it is not yet proven. So definitely, if the patient is having raised serum uric acid level, because there is some associated cardiovascular risk, I would like to reduce the serum uric acid levels. And it is not required that patient should be on treatment lifelong. We can monitor the serum uric acid levels, and once it has been controlled, then we can discontinue the treatment.
Thank you so much, ma'am. Anybody else has any other thoughts on this? So, yes, Dr. Devashish.
Yeah, so I have a question on that. I mean, again, my understanding was that if it is high, then it would be high throughout life, or at least so long as there is obesity or overweight. So are we expecting it to become normal on its own after discontinuing therapy after 3 months or 4 months or whatever time we discontinue it after? And what's the rationale for that?
So maybe Dr. Devashish, I'll answer that question as well. So the idea here is that when we start treating, maybe we are using dietary modification, lifestyle modification, we are changing some of the drugs like thiazide diuretics, beta blockers, which can increase uric acid levels, exercise. So all those things while you are also treating. So eventually, hopefully, those things will catch up, and that will give you an option of reducing the drug. Dr. Krishnaraju, I'm going to come to you. Just give me a minute or two. So in the field of economics, where you can't do a randomized controlled trial, like in the global economy and everything, or sociology, they look for natural events. They look for events which are occurring naturally, and then they match it with some other event which is occurring naturally without any selection bias, because these are as close as randomized trial as they can get in uric acid treatment, we have something like this. Although in medicine, we typically like to control, that is why we call it a control trial, randomized control trial. But in the field of uric acid, we have something like this. We have got a group of people who have urate deposition in the form of gout, kidney disease, or whatnot. And they are taking these drugs. Their uric acid level is elevated. They are taking these drugs and we are reducing their levels. So we have a group of people in any country who are on these drugs. And if we apply these principles, it's very easy. You just take 1,000 of those patients, propensity match them with another 1,000 patients who are not taking those drugs with uric acid levels, whatnot. Match as many parameters as you can, because now you are not controlling them, but in a way you are doing a prospective analysis for that. So there are numerous studies of patients with gout who are on therapy. That is the only factor which is not equal between the two groups. Patients who have gout, who have an indication for uric acid lowering therapy, and they are on the therapy, and their uric acid is targeted below that. When you propensity match them with another group of people who have got those risk factors with high uric acid, between the two groups, the cardiovascular outcomes are no different. And if you go by certain studies, then the group taking febuxostat actually have a slightly worse cardiovascular outcome for reasons that we don't know. And that has been challenged. And truly speaking, it's possible maybe after a year or two, FDA will take that black box warning away. But right now, that is all that we have got. And because we don't have a rationale of why febuxostat may cause worse cardiovascular outcome, the debate is far from over whether that data is correct or not. But regardless, at least some of those key points we have got in terms of whether reducing uric acid level will do anything to the gout population or not. Not a good set of data because the groups are not perfectly matched. One group has gout, other group does not. There are innumerable studies like that. We take whatever we have got. Dr. Krishnam Raju, your comment, please. Your hand has been up for a long time.
Yeah. There are two clinical scenarios where the heart and the uric acid are involved. One is adolescent or adult cyanotic congenital heart disease, where because of the polycythemia, you have very high uric acid levels, and they do have renal issues, they do have arthralgias, arthritis, etc. And that is where we also have been using very aggressively these, uricosuric drugs. Second clinical scenario, which I came to know about it recently, is there is something called acute tumor lysis syndrome. So malignancy, you give a chemotherapy or you give a radiation, immediately it kills the tumor. As it is killing the tumor releases a lot of cells, they degrade, and suddenly there is a toxic level of uric acid circulating in the body. And they have found that sometimes this is associated with heart failure or acute coronary syndromes, arrhythmias in some people. Maybe these are the ones who are already predisposed to some of these complications. So they have come out with a new treatment, a recombinant urate oxidase. This is an intravenous medication, a recombinant urate oxidase. Its pharmacological name is
Rasburicase. We have been yes, sir. We have been that has been a part of a lot of chemotherapy protocols as literally as a protocol, prophylactic treatment. Absolutely. Go ahead, sir. Sorry, I interrupted you.
Oh, fine. So that need to be given intravenous. So in oncology area, this has gained some significance. So these are the two areas, other areas where sometimes we may have to take a decision. Tumor lysis syndrome resulting in cardiovascular problem or cyanotic heart disease.
Right. Raghu sir, you have something to add?
I wanted to draw another analogy which adds to the conundrum. You have patients with high triglycerides. Now we know that triglycerides is an independent risk factor of coronary artery disease. For the last 5 years, both the American NCEP and the ENHANCE and the NICE studies, they've all shown that reducing triglycerides has of no value at all in terms of reducing the cardiac events. Now, despite this, it has been our practice, it's been my practice, I don't know about you all, that if we often do add a fibrate to the anti-cholesterol regimen, that is statins. Now, the current recommendation is you give fibrates or even niacin only if the patient has triglycerides of more than 450, because then it is to prevent pancreatitis. But we tend to use it regardless of the guidelines. So, what's your thought on this? I mean, the analogy is very similar to what we are now talking about hyperuricemia.
Sir, I'm so glad you brought this up. I'm feeling very bad. I didn't invite. Yeah, I didn't have you in one of the panel 2 weeks back when we discussed hypertriglyceridemia. I will not discuss any further because I think it will deviate our topic. But I think the analogy is to a certain degree valid, because here also we are looking at risk association versus a target therapy. And I think that is where the basic difference comes. Risk association versus can that be a target for therapy, like lipoprotein little a and all those things. But I would stop there in terms of lipids, because I think that will change our discussion. Anybody else who hasn't shared their thought yet? I will ask Dr. Prashant. Dr. Prashant Kulkarni is our cardiologist at Care High Tech City. Dr. Prashant, how do you handle hyperuricemia in your practice, hyperuricemia with no gout in terms of cardiovascular disease?
Yeah, hi, good evening, everyone. Probably if they are asymptomatic, then obviously comorbidities have to be taken care and then follow up them closely. Um, like how they develop any symptoms, and then obviously treat the other comorbidity as sir was mentioning, hypertriglyceridemia and other such comorbidities.
Do you do uric acid lowering therapy, pharmaceutical uric acid lowering therapy? What's your take on that?
I feel, yeah, like if they are asymptomatic, then obviously anything which will increase their uric acid level, those interventions, especially diet and all, especially if they are into like non-vegetarian, maybe I'll ask them to curb that to an extent, and then just follow up them with uric acid levels, and maybe as I was mentioning, maybe I'll target the other parameters rather than straight away starting with any uric acid lowering medications, unless of course if the levels are too high and their risk of developing gout is very much there.
Okay, thank you, Prashant.
Yeah.
Anyone else has got any other thoughts regarding this? There are a lot of people in the audience who have not spoken yet. Anyone, please share your thought about what you do. As you have seen in the last 50 minutes or so, we are really not looking for the correct answer. We're just looking for practice patterns and your rationale behind it. Anyone else who has got any thoughts? Let me pick up. Let me pick anyone. Dr. Prithvi, can you tell us what is your thought process? What do you do in your practice? Dr. Prithvi?
Yeah, good evening to everyone. So, in my routine practice, I also start if the level is more than 7 when the uric acid levels. I'll monitor it after 3 months or so, and if it is less than 6, then I will just stop it, and again I will watch it after again 3 to 4 months.
Thank you so much. Thank you so much, Dr. Prithvi. Dr. Zemi, if I'm saying it right, Dr. Sufyan Zemi, could you please give a brief introduction of you? Who are you? And then tell us what do you do in your clinical practice? Okay, maybe I have to unmute her. Okay. Dr. Zemi, are you able to hear us? Okay, we'll get back to you. Uh, uh, Let me pick up somebody else. Dr. Sandeep. Dr. Sandeep, are you there? Can you
Yes, sir.
unmute yourself and can you please tell us?
Yes, yes, sir. Can you hear me, sir?
Yes, we can. Tell us your thought process about this, please.
Yes, sir. Yes, sir. Thank you. Regarding my thought process, I think it's best left alone because not as a. I just have a doubt whether what do we tell the patients if they ask us what is this febuxostat going to do to me? Is it going to relieve my symptoms or my cardiac disease is going to get it down? So I don't know what are we going to tell them, convince them if I prescribe them on that drug? So generally, I'm not prescribing them on any drug right now, though I have very few patients coming with those values.
Dr. Sandeep, can you give a brief introduction of yourself, please?
Sir, I'm Dr. Sandeep, sir. I'm from Vijayawada. I work at a cardiac consultant at Anoop Hospitals from Vijayawada. Hello? Sir, can you hear
Thank
me,
you.
sir?
Yes, sir. Yes, we can hear you. Thank you. Thank you so much. So to answer your question, patients come us not for us to follow guidelines. They don't come us so that we just follow guidelines, right? Because if that was the case, then a computerized algorithm would do it. They come us for our opinion. And we base our opinion based upon whatever literature we have got, whatever guidelines we have, but also what we see and learn in the community. And and that is why I think few of us, based upon our years of practice or years of observation, we have seen that certain things they do make change, even if I have not published it, because many of the time, we don't have that bandwidth to just keep publishing whatever we have got. So that is the opinion. Now, opinions are always subject to debate and discussion. That is the whole reason why we discuss like this. We understand what the rationale is and we discuss about it. That doesn't necessarily mean we just follow blindly, but neither we should follow guidelines blindly. We should individualize, and that's what we should put on. Okay. Anybody else has got any other thoughts? Maybe Dr. Gautami. Do we have Dr. Gautami here? Dr. Gautami, could you please unmute yourself and
Sir,
share your thought process about this?
yes, sir. Good evening, sir. Can you hear me?
Hear you. Please go ahead.
Yes, sir. I'm Dr. Gautami. I'm working as assistant professor at Nizam's Institute of Medical Sciences. So, sir, I've been practicing only since 1 year. So, to my knowledge, I understand that when serum uric acid is elevated, there is definitely severe risk associated in that patient. So I would like to look into the other comorbidities which are causing that, which are also responsible for the elevated uric acid. So I would like to address like if the patient has any hyperlipidemia. So I would like to put him on cholesterol lowering drugs like atorvastatin or rosuvastatin, so that it will also will be useful for reduction of the uric acid. If the patient has hypertension, I would like to put him on valsartan preferably. So I would not like to, from the data which I went through, that putting the patient on febuxostat would reduce a severe risk actually. So I would like to go with underlying risk assessment and leave uric acid just as a marker, just to look into it, not individually treat with febuxostat.
Thank you so much, ma'am. Thank you for your comment. Do we have Dr. Muhammad Ali here? Dr. Ali, could you please unmute yourself and share your thought process with us? Dr. Ali? No.
He left, I guess.
Okay. Let us get to the closing comments. In the meantime, if you have any other thoughts, please unmute yourself and feel free to speak. Praneeth, your closing comments on the case that we discussed and overall discussion.
Yeah, so a few learning points from my side. I didn't know that febuxostat had an FBA warning. So that is an eye-opener for me. So I will be careful enough because most of them I'm writing, I need to be aware of this thing. I try to find an alternative or try to skip completely. Yes, Marker, the point shared by Dr. Krishnan Raju regarding the importance of diet and alcohol in reducing uric acid level versus using pharmaceutic agents is well appreciated. So encouraging diet and alcohol restriction to reduce uric acid levels is again a learning point for me. And yes, Raghu sir's point of treating it as when it is very high, you're not totally comfortable leaving them alone, having some threshold or some soft corner for some patients where you're really scared or the patient is equally scared and you want to reduce the uric acid levels. So selectively using for some patients. Again, using which drug is a challenge now with febuxostat being the favorite, having an FDA thing, and you're not too comfortable or not had enough experience to use allopurinol is a challenge, but I need to look forward to. So these would be my comments from today's.
Thanks, Praneeth. Dr. Krishnamraju, sir, I am unmuting yourself. Can you just share your closing comments on this about the topic and about the discussion?
Yeah, I think uric acid is at the level where cholesterol was 15, 20 years back, and triglycerides was even now. Maybe last 5 years, the outlook has changed. But overall, when you look at the total data coming from all over the world, now it is more or less like that with or without gout, if the uric acid is high, it is always good to try the alcohol reduction or cessation, and dietary modification, exercise, control your blood pressure. Maybe valsartan could be one of the drugs, and then statins, they're good. And Pranit was saying that you may not be comfortable with allopurinol, but there is a clear distinction there. Both are effective. Both allopurinol and febuxostat, both are effective. The dividing line is the renal function. If the glomerular filtration rate is above 30, you could use either. But if the glomerular filtration rate is less than 30, no allopurinol, but febuxostat is very safe. So even if there is a renal dysfunction, febuxostat is much, much safer than allopurinol. So that is where I think there is a dividing line, but you could use both of them, and both are equally effective. But febuxostat is much more effective than allopurinol in the standard dose. Allopurinol, you get 100 milligrams per day, but febuxostat of 80 milligrams is equivalent to 300 milligrams or 400 milligrams allopurinol. Febuxostat can also be given up to a max dose of 120 milligrams once a day. So though there was a black box warning, at the moment there is no continuing concern on that as of now. So we continue to use it. Both are good options, but depending on the renal function.
Perfect. Thank you so much. Raghu sir, your closing comments on the session? I think Raghu sir, are you there? No, I think he left.
No, he left.
Devashish, your closing comment on the session and the topic?
Thanks. Yes, it was wonderful learning and got to know a lot of contrasting viewpoints. I am also of the viewpoint that we should work closely with our patients in terms of diet and lifestyle modification, alcohol cessation, and good control of blood pressure and cholesterol, which we know are independent risk factors. And hopefully with all of this, we can bring down the uric acid levels as well as make a positive impact on their cardiovascular risk. So that's my takeaway for today.
Thank you so much. We are 8 minutes out of our scheduled time. Anybody else, any other closing comments, any other suggestions about the topic, about the session? Anything you do differently in your practice? Anybody for whom allopurinol is the drug of choice? No other thought process? Okay.
Anoop?
All right. Yes, sir. Yes, sir.
See, the uric acid has come into a sharp focus because of the thyrocare people. because they do so many unasked tests. Okay. So even without being asked, the patients will come to you with a whole sheaf of papers, which contains not only uric acid, but also arsenic, lead, zinc, etc. So that is the problem.
Yes, yes, absolutely. So just to make sure everybody is in the same page, I don't know if you guys have seen any that package test that Thyrocare does. They have like a 40-page test with one single value on each page, and they pretty much test for every single thing known to mankind, including insulin levels and lithium and arsenic and copper and manganese and selenium levels. And they all charge literally cheap. Like they are some of the standard blood tests in the corporate hospital. I don't know what they do, but you're absolutely right. You have the numbers on your face, and patient is confused. And sometimes you have to do something. All right, okay. Any other thought process? One question came, sir. Krishna Raju sir, I'll ask you before you go. One question came is any thoughts on vitamin C and hyperuricemia? Do you use vitamin C to treat hyperuricemia or modify risk?
I am aware there are some studies where they did use vitamin C, but I don't use it at personal level. But the literature does have a reference to usage of the vitamin C.
Yeah, I think that whole vitamin C thing came when Linus Pauling, who is, double Nobel laureate, this is just a general knowledge. This guy, after getting 2 Nobel, so genius, he switched his entire study on vitamin C. And pretty much every single disease at that time, I'm talking about 1970s and 80s, pretty much every single disease known to mankind had some correlation with vitamin C at that time. So,
including COVID.
Yes, COVID now, sir, Limsi tablets are not available. They are black marketed.
Yes, they're black marketed. was asking for it for his wife. They couldn't find it any one of our pharmacies.
Yes, it is black marketed. It is black marketed. So, of the audience, if you guys have, feeling bored anytime, just Google Linus Pauling. It's a fascinating story about his life. One of the two person who got like 2 Nobels, and the only guy who got Nobel in physics and biology, like 2 completely unrelated subjects.
No,
and then
Curie,
his
Yes, Mary Curie had
Madam Curie.
Madam Curie had 2 Nobels
in
physics and chemistry.
So those are the only 2 people in the world right now who has got 2 Nobels. The story of Linus Pauling is fascinating. This is something, if you are sometimes free, then maybe just browse through it. If nobody else has any other thoughts to add, we'll close the session. I thank each one of you for participating. And as I said, this is a new venture we are trying to test out. So please, if you have any suggestions about the topic, about the format, anything that would make our learning, not just mine or yours, better, I'm very appreciative of that. You can reach out to me anywhere. My email ID, my phone number, everything is displayed on the invite. And we'll be very happy to see you again next Wednesday. We are doing this every Wednesday, 7:30, and the ID remains the same. Thank you all for joining, and have a good night. Stay safe. Stay away from COVID. Take care, guys. Good night.